You know, usually when we talk about a medical diagnosis, there's this expectation of like total clinical precision. It feels almost like engineering.
Right, like it should be totally
Yeah.
binary.
Yeah, exactly. You break your arm, the x-ray shows that jagged white line, and the doctor just points and says, yep, there it is, broken.
But then you step into the world of pathology, and suddenly that clean binary X-ray machine is, well, it's essentially useless. We're
Yeah.
looking at a diagnostic landscape that is systemic, microscopic, and honestly a lot more murky. We're dealing with the fundamental nature of disease itself.
It really is the absolute definition of diagnostic muddy waters. But I mean, that is exactly why we are here today.
Exactly.
For you listening, whether you are a medical student staring down the barrel of the boards, a young professional sharpening your clinical reasoning, or just an intensely curious learner trying to understand how the human body breaks down.
Our mission in this deep dive is to master the foundational concepts of pathology. We're going to look at how a single microscopic failure cascades into, full system collapse.
And to do that, we have to start by understanding how pathologists actually think. You can't just memorize a list of symptoms. You need a framework.
Right, the classic approach to disease analysis rests on four absolute pillars. That's etiology, pathogenesis, morphology, and clinical significance.
Which are so crucial.
They really dictate everything. Etiology is the root cause, like, is the disease genetic or is it environmental? Pathogenesis is the temporal sequence of events. It's the step-by-step cellular domino effect.
Right.
Morphology is what we actually see when we look at the tissue, the structural changes, both gross and microscopic. And finally, clinical significance. How does this cellular damage translate into the signs and symptoms you see in the patient sitting in front of you?
I always think of this framework like a forensic investigation. You can't just look at the crime scene, which would be the morphology, the structural damage.
Yeah, you need more than that.
Exactly. If you want to solve the case, you have to figure out the motive, which is the etiology. And you desperately need the exact timeline of events, the pathogenesis, to understand why the victim, meaning the patient, is exhibiting their specific symptoms.
That's a great way to look at it. If we connect this to the broader picture, you really can't understand massive events like organ failure without first visiting that microscopic crime scene.
Yeah.
How and why do the building blocks, the cells themselves, get injured in the first place?
Well, let's unpack that. When you look at the pathology notes, hypoxia is listed as the most common cause of cellular injury, basically a lack of oxygen.
Right.
And this is primarily driven by ischemia, which is a loss of blood supply. But I've always wondered, why is ischemia considered so much worse for a cell than just standard hypoxia, like if you were suffocating?
That is a really crucial distinction. With standard hypoxia, say, you're at a really high altitude, your oxygen is low, but your blood is still flowing.
Okay.
You are still delivering glucose, and you are still washing away toxic metabolic waste. In ischemia, the blood flow stops completely.
Oh, wow. So it's cut off entirely.
Exactly. So not only is the cell starved of oxygen, meaning it can't synthesize ATP for energy, but it's also starved of nutrients, and all its acidic waste products just build up locally. It's a double hit.
Okay, so when that ATP production completely halts, the cell is in crisis mode. I like to picture the cell as a medieval castle under siege.
I like that.
When the power goes out, that's the ATP depletion, the defensive walls begin to fail. The sodium-potassium pumps on the cell membrane stop working. And since sodium isn't being pumped out, water rushes into the cell following the salt, right? So the cell just swells up like a balloon.
Exactly. The pumps stop bailing out the moat, and the castle floods. And inside that flooded cell, the mitochondria start to fail.
Which is bad news.
Very bad. Without oxygen to accept electrons, you get a massive buildup of oxygen-derived free radicals, like superoxide and hydroxyl radicals. These are highly unstable molecules that essentially act like, well, molecular wrecking balls, tearing apart the cell's lipids, proteins, and DNA.
But the cell doesn't just sit there and take it, right? It tries to fight back using antioxidants like vitamins A, C, and E, or protective enzymes like catalase and superoxide dismutase.
Right, those are the cellular defenders trying to neutralize those free radicals back into harmless water and oxygen.
So they're putting up a fight.
They do their best. But if the ischemic siege doesn't lift, the injury goes from reversible to irreversible. The physical cell membrane ultimately ruptures. And when that happens, all the intracellular enzymes leak out into the bloodstream.
So is this leakage essentially the cellular equivalent of sending up a distress flare?
That is a perfect analogy. When you draw a patient's blood and you see high levels of troponin, that isn't just a random chemical marker. Troponin belongs strictly inside the muscle cells of the heart.
Oh, I see.
If you are seeing it in the blood, it means heart cells have physically burst open.
Hmm.
This is clinical significance derived directly from pathogenesis. The same goes for seeing AST or ALT liver enzymes in the blood. It means liver cells are dying.
And when a cell hits that point of no return, pathologists call it necrosis. If you look under a microscope, you can actually see the cell's nucleus die in 3 distinct stages, right?
Yep, you can see it happen.
First is panosis, where the nucleus shrinks down into a tight, dark ink dot. Then karyorrhexis, where it shatters like glass into fragments. And finally, karyolysis, where those fragments just fade away into a ghost-like nothingness.
And once that cell has faded away, the body has to clean up the mess. You can't just leave dead tissue sitting around. This triggers the body's innate counterattack, which is inflammation.
Right. Acute inflammation is the immediate response. The body sends in neutrophils, which are the first responder white blood cells.
Exactly.
This whole process is orchestrated by chemical mediators, cytokines like IL-1, IL-6, and tumor necrosis factor. These are the chemicals that travel to your brain and give you a fever, while locally they activate your blood vessels to become leaky so white blood cells can squeeze through into the tissue.
The body also releases a cytokine called IL-8, which acts as a very specific homing beacon just for neutrophils, guiding them directly to the site of the dead cells. Ideally, this acute inflammation clears out the debris and leads to complete resolution and regeneration.
But it doesn't always go perfectly, right? Sometimes it leaves a scar or forms a localized abscess. Or, if the body can't clear the debris, it shifts into a smoldering chronic inflammation.
Yeah, that's when things get complicated.
And then there are times when the immune system isn't just cleaning up a mess, it actually creates the mess. I'm talking about hypersensitivity reactions.
Yes, the immune system can be entirely too overzealous. There are 4 types of hypersensitivity. Type I is your immediate IgE-dependent reaction. This is anaphylaxis or an asthma attack.
Right.
Type 2 is antibody-mediated, where IgG or IgM mistakenly tags specific target cells for destruction, like in autoimmune hemolytic anemia, where the body attacks its own red blood cells. And type 5 is the delayed cell-mediated response driven by T cells. The classic example there is the PPD skin test for tuberculosis.
Wait, hold on. You jumped from antibodies attacking specific cells in type 2 straight to T cells in type 4. What exactly is type 3 doing differently?
Type 3 is the wild card, and it is vital to understand. It is immune complex mediated. Instead of an antibody attacking a specific cell, the antibodies bind to free-floating antigens in the blood, creating these massive clumps or immune complexes.
Like getting a bunch of burrs stuck together in your hair.
Exactly. And because they are so large, they eventually get stuck in the walls of small blood vessels. When they deposit, the immune system spots them and triggers a massive inflammatory response right there on the vessel wall.
Oh, wow.
Neutrophils arrive, get confused, and dump all their toxic lysosomal enzymes directly onto the endothelium. The immune system literally chews up its own blood vessels trying to get to the complexes, causing what we call fibrinoid necrosis. You see this heavily in systemic lupus.
That makes total sense. The cleanup crew accidentally destroys the building. So we've seen how the immune system attacks invaders and sometimes itself. But what happens when the body's internal manufacturing process goes rogue? Like, what if it starts producing proteins that the immune system can't even recognize to clean up?
Then we enter the realm of abnormal protein deposition and unregulated growth. Let's start with amyloidosis. Amyloid isn't just one specific protein. It's a classification for any misfolded protein that physically alters its structure to form beta-pleated sheets.
Right, and because of that specific folded geometry, the body's enzymes can't break it down. It just builds up in the organs. If you want to diagnose it, you use a Congo red stain. And here's the classic board phrase everyone has to know under polarized light. Amyloid shows an apple-green birefringence.
That apple-green birefringence is an incredibly high-yield visual hallmark. Birefringence just means the physical structure of the protein is actually splitting the polarized light, reflecting back that bright green color.
And speaking of rogue biology, we have to touch on neoplasia, or cancer. The foundational teaching here is that carcinogenesis is a multi-step process. It starts with initiation, a genetic mutation usually caused by a carcinogen, and is followed by promotion, where that mutated cell is stimulated to multiply.
And as they multiply, how we name them tells you exactly where they came from. Tumors arising from epithelial cells, the linings of your organs and skin, are called carcinomas. Tumors arising from mesenchymal cells, your structural connective tissues like bone, muscle, and fat, are called sarcomas.
But let me challenge that classification for a second. Why do we care so much about classifying the tissue origin as mesenchymal versus epithelial? Does knowing it's a sarcoma versus a carcinoma actually change how we approach the patient? Or is it just academic bookkeeping?
Well, it changes absolutely everything. Cellular origin dictates the tumor's entire personality, and most importantly, its highway for metastasis.
Really? How so?
Well, carcinomas generally love to spread through the lymphatic system. So if a patient has breast carcinoma, the very first place you check is the axillary lymph nodes. Sarcomas, however, prefer spreading hematogenously, right through the blood vessels.
Wow. Okay.
Yeah, so if a patient has an osteosarcoma in their leg bone, you don't just check the lymph nodes, you immediately image the lungs because the blood carries those tumor cells straight to the pulmonary capillary beds.
Form truly dictates function, and origin dictates the spread. So how do we catch these pathologies early? Let's talk about diagnostic windows, things we can see on the skin or easily draw from the blood. For scare pigmentation, the absence of melanin can signal autoimmune issues, like vitiligo, where the body attacks its own melanocytes, or genetic issues, like oculocutaneous albinism.
And don't forget the syndromic forms of albinism, like Chiari-Higashi syndrome. That's a microtubule dysfunction where the patient not only has albinism, but also a severe susceptibility to infections because their white blood cells can't properly move to attack bacteria.
Right.
On the flip side, hyperpigmentation can be a huge clinical clue. An overactive pituitary gland in Addison's disease produces excess ACTH, which stimulates melanocytes, causing generalized darkening of the skin.
But the real diagnostic goldmine is just a simple drop of blood. Red blood cell morphology is basically a masterclass in reading clinical significance from a microscope. If the size is wrong, it's anisocytosis. If the shape is wrong, it's poikilocytosis.
And every specific shape tells a story.
Let's run through some of the heavy hitters because this is where the puzzle pieces snap together. If you see spherocytes, red blood cells that look like solid spheres instead of the normal donuts, it means the cell membrane is defective, often from hereditary spherocytosis or autoimmune hemolysis.
Right.
And if you see target cells, it looks like a bullseye pointing to thalassemia or liver disease.
What about schistocytes?
Oh, schistocytes, or helmet cells. This is a brilliant mechanism. These are fragmented red blood cells. Think of microclots forming in your tiny blood vessels. As the red blood cells try to squeeze past, the fibrin strands in the clot act like cheese wire, literally slicing the red blood cells in half. It screams microangiopathic hemolytic anemia.
That cheese wire analogy is spot on. You might also see bite cells, which occur in G6PD deficiency. Here, oxidative stress causes the hemoglobin to clump together into Heinz bodies.
Okay.
When these cells pass through the spleen's macrophages literally take a bite out of the cell to remove the Heinz body, leaving a permanent divot.
So the spleen acts like the body's quality control inspector.
Exactly. And when that inspector is missing or on strike, you see Howell-Jolly bodies. These are little remnants of nuclear DNA that the red blood cell was supposed to expel. A healthy spleen would instantly filter those defective cells out.
Oh, wow.
So if you see Howell-Jolly bodies on a blood smear, it immediately tells you the patient likely doesn't have a functioning spleen.
It's incredible how much you can learn just from cell shapes. But those cells still need roads to travel on. Let's move into vascular pathology. When the blood vessels themselves get inflamed, the vasculitides, the entire organ system downstream is compromised.
And we categorize these based on the size of the highway they affect.
Right, if we stick with the highway analogy, large vessel vasculitis is like a massive interstate pileup. Takayasu arteritis typically hits the aortic arch in young patients under 50. It blocks the massive interstates leaving the heart, leading to weak or absent pulses in the arms, and can even cause blindness.
Yeah, it's very severe.
Then you have medium vessels like the state highways, thromboangiitis obliterans, or Berger's disease. This is classically seen in young male smokers who present with severe pain and ulceration in their fingers or toes because the local highways are completely shut down by inflammation.
And Kawasaki disease in children also hits medium vessels, specifically the coronary arteries of the heart, which is why it's so dangerous, though uniquely treatable with immunoglobulins.
But when you get down to the residential streets, the small vessel vasculitides, you need a different diagnostic map entirely. We rely heavily on ANCA blood tests. Granulomatosis with polyangiitis is linked to PR3-ANCA and causes devastating granulomas in the respiratory tract.
Right.
Eosinophilic granulomatosis with polyangiitis is linked to PANCA and presents with asthma and high eosinophils.
If we follow those vascular highways into the chest, we have to consider pulmonary malformations. A key concept here is communication. A congenital pulmonary airway malformation, or CPAM, consists of cysts that do communicate with the rest of the tracheobronchial tree.
Okay, got it.
But a bronchopulmonary sequestration is a mass of lung tissue that does not communicate with the airway and has its own completely separate blood supply branching right off the aorta. It's essentially rogue lung tissue.
Let's shift from oxygen to nutrients and detoxification. The gastrointestinal tract and the liver. In the GI tract, an absolute classic morphology is achalasia. The lower esophageal sphincter physically fails to relax, so food just backs up.
Yeah, that's a tough one.
If you do a barium swallow x-ray, you see the esophagus dilate massively, tapering down to a narrow point at the sphincter, the famous bird beak sign.
That bird beak sign is caused by a loss of the specific nerve ganglion cells that tell the sphincter to relax. In South America, this is famously a secondary complication of Chagas disease.
But the liver is where the metabolic pathology gets incredibly dense. Liver dysfunction often flags its presence systemically via jaundice yellowing of the skin when bilirubin can't be cleared and builds up past 2 to 3 milligrams per deciliter.
And if that injury becomes chronic, you get cirrhosis. The liver becomes a stiff, fibrotic rock. Blood trying to flow through the liver hits that resistance and backs up, causing portal hypertension.
Which causes a whole cascade of issues.
Right. That backup pressure forces blood to find detours, creating engorged veins around the umbilicus called caput medusa and dangerous esophageal varices that can rupture and bleed.
The causes of that cirrhosis are wildly varied. You have alcoholic liver disease, which starts as reversible fatty change but progresses to irreversible central vein fibrosis. Then you have genetic metabolic disorders.
Like Wilson disease.
Yes, Wilson disease is a mutation in the ATP7B gene causing toxic copper to accumulate, which famously deposits in the cornea as Kaiser-Fleischer rings. Hemochromatosis is iron accumulation from the HFE gene, which damages both the liver and the pancreas, earning the terrifying nickname bronze diabetes.
Let's look deeply at alpha-1 antitrypsin deficiency because it perfectly illustrates systemic pathogenesis. Alpha-1 antitrypsin is a protective enzyme made by the liver. Its job is to travel to the lungs and stop a destructive protein called elastase from chewing up lung tissue. In this genetic deficiency, the liver produces a misfolded version of alpha-1.
So it basically gets stuck.
Exactly. The misfolded protein gets physically trapped inside the liver cells. You can see these under a microscope as PAS-positive globules. Because it's trapped, two things happen. First, the physical buildup destroys the liver, causing cirrhosis. Second, because the protective enzyme never reaches the lungs, elastase runs wild and destroys the alveolar walls, leading to early-onset panosynor emphysema. One mutation, two completely different organ failures.
It's all connected. Speaking of connections, the liver also suffers when the heart fails, right? Chronic passive congestion leading to a nutmeg liver pattern.
Yes, and this brings us full circle to our very first topic. If the right side of the heart is failing, it can't pump blood forward efficiently. So the blood backs up into the hepatic vein, heavily congesting the liver. Now think about the microscopic liver lobule. The cells in the very center, around the central vein, are the furthest away from the fresh arterial oxygen supply.
So when the blood stagnates, those central cells are the first to suffocate.
Precisely. The passive congestion causes central lobular necrosis simply because of hypoxia. The ischemic siege we talked about earlier happens right there in the center of the liver lobule, creating a mottled appearance that looks just like grated nutmeg.
Okay, final stretch of our deep dive. Neuromuscular, musculoskeletal, and CNS pathology. In the central nervous system, meningitis is a literal inflammation of the pia and arachnoid layers of the brain. If you're looking at an MRI and see a ring-enhancing lesion, you have to differentiate between a bacterial cerebral abscess or, particularly in an immunocompromised AIDS patient, toxoplasmosis.
We also have to mention prion diseases like Creutzfeldt-Jakob disease. Prions are fascinating and terrifying. They are normal brain proteins, PRPC, that spontaneously change their physical conformation into a beta-pleated sheet. They trigger other proteins to do the same, causing microscopic holes in the brain, a spongiform change leading to rapid dementia.
Moving down to the joints, we see crystal arthropathies. And here, the specific shape of the microscopic crystal tells you exactly what the chemical culprit is. Gout is caused by uric acid, forming sharp, needle-shaped crystals. Pseudogout, on the other hand, is caused by calcium pyrophosphate. These crystals are rhomboid-shaped.
And there's a massive clinical pearl here. If you see a patient under 50 presenting with pseudogout, you can't just treat the joint. You must screen them for the underlying metabolic 4Hs. Hemochromatosis, hyperparathyroidism, hypophosphatemia, and hypomagnesemia.
Finally, let's look at the intersection of muscles and nerves. At the neuromuscular junction, we have two major autoimmune myasthenic syndromes. Myasthenia gravis, where autoantibodies attack the acetylcholine receptors on the muscle side, and Lambert-Eaton syndrome, where antibodies attack the calcium channels on the nerve side.
Right, two very distinct targets.
But wait, if both conditions block the signal, don't they both just cause generalized muscle weakness?
They both cause weakness, but the mechanism makes the clinical presentation drastically different. In myasthenia gravis, the nerve releases acetylcholine perfectly fine, but the receptors on the muscle are blocked. As you keep trying to move, you deplete your acetylcholine stores, so the weakness gets progressively worse with use.
And Lambert-Eaton.
In Lambert-Eaton, the calcium channels on the nerve are blocked, meaning the nerve struggles to release acetylcholine in the first place. However, with repeated, forceful muscle stimulation, you can eventually force enough calcium to build up in the nerve terminal to trigger the release. So counterintuitively, their muscle weakness actually improves with use.
That is a brilliant distinction.
Furthermore, Lambert-Eaton is critical to identify because it is frequently a paraneoplastic syndrome. The antibodies are actually created by the immune system to fight a hidden small cell lung cancer, but they cross-react with the neuromuscular junction. Diagnosing the muscle weakness might be how you find the lung tumor.
It is wild how the entire body is functionally tethered together. To summarize what we've unpacked today, we started at the cellular level, tracking how fundamental injury, often just the lack of ATP from hypoxia, cascades into inflammation, alters tissue morphology, and creates systemic, predictable clinical signs across the vascular, hepatic, neuro, and musculoskeletal systems.
We followed the timeline from the ischemic cell all the way to the failing organ.
So, for you listening, here is a rapid-fire clinical exercise to test what you've absorbed. You have a 55-year-old male presenting with a swollen, incredibly painful knee. Joint aspiration reveals weakly, positively birefringent, rhomboid-shaped crystals. Based on today's deep dive, what is the diagnosis, and what are the 4 H's you should immediately screen this patient for?
Take a second to lock in your answer. Okay, the rhomboid crystals are the giveaway. It's pseudogout. And those 4 H's you need to screen for: hemochromatosis, hyperparathyroidism, hypophosphatemia, and hypomagnesemia. I want to leave you with a final thought to ponder on your own. Earlier, we discussed how both prions in the brain and amyloidosis in the organs involve perfectly normal proteins physically changing their shape into beta-pleated sheets.
Yeah.
By simply changing their physical geometry, they become virtually indestructible to the body's normal clearing mechanisms. Consider how the physical geometry of a single protein folding incorrectly can override your entire immune system and ultimately destroy complex organ architecture. How might future medicine have to solve a structural geometry problem rather than just a chemical one?
That is an incredible concept to chew on. It brings us right back to where we started. When you step into pathology, you realize the body isn't just binary engineering. The X-ray might look clean, but down at the molecular level in those murky, muddy waters, the real forensic investigation is just beginning. Keep investigating. We'll catch you on the next deep dive.